So in this session, we'll continue our discussion for the demand for medical care. So how do we analyze how people demand medical care in our healthcare markets? So for this session, we'll try to see follow the logic that the shifting demand for health to demand for medical care, given specific illnesses. No? How do we shift from demand for health to demand for medical care? Because when you have diseases, for instance, you need to access healthcare services in order for you to achieve better health as well. Then we need to understand how to derive demand curves for medical care from what we call indifference curves. So you remember our discussion of indifference curves. These are combinations of health and other goods that give the same amount of utility or satisfaction or happiness, as we might call. So, and how do these relate to the demand for health? For health, then we try to interpret demand curves as value measures. So, demand curves as expression of our what are valuable or what's important for consumers. And then we learn how health insurance as a unique variable in healthcare markets. How does it alter the pricing for medical care and how it affects demand curves as well. So let's revisit our indifference curves for health and other goods. So, so you remember our utility function. Our utility is determined by your uh, combination of your goods, consumption of X goods, and your H as a good or as durable good as well. So this is a vector for X is a vector or collection of other goods, and health is your H is your health, considered as a good by itself. So consumers or those in the market must pay for X and medical care to produce certain level of H or health status. And what limits this ability to pay for X and medical care is the level of income of the consumer. So we also mentioned that the production process will translate medical care, so medical care, into health. So H is a function of your medical care, and it's the production function curve. So subject to what we call diminishing returns, the more medical care that you are able to get, the less is the amount of H in return. So we have your marginal diminishing returns, no? Because the more medical care you access does not mean that you will have more health automatically. So there's a decreasing amount of health for an increasing amount of medical care that one access, and it depends on the curves of the disease. No, so subject to diminishing returns. So the G prime M. So this is the function of how medical care is consumed. The rate at which health improves for a small change in M is decreasing. So diminishing return says that the rate at which H improves uh, becomes smaller, still positive though. The more you consume M, you still have a positive impact on health. But the rate at which health improves uh, becomes smaller for a change in M. So it's decreasing. So this is the curve that we are talking about. So you have your medical care. So for the consumption of medical care, the rate at which health is improved decreases as well. So the consumers must pay for X, so this is the vector or collection of goods, and medical care, M, to produce health. And this is this combination of X and M that produces health. And this is constrained by income. We will show that later on. So the production process translates medical care into health. So this is your production process. function, H equals G sub M. So the more medical care, so there's a positive relationship that your access to medical care will improve your health status. So subject to diminishing returns, the G sub G prime M, the rate at which health improves or small change in M is decreasing. So the next slide will show the production possibilities given a feasible combination of X and H. So given a certain amount of budget and production function. And we'll show to you why the curve is concave. So concave curve looks like this because of the reality of diminishing returns. So utility maximization will imply that the consumer will choose a bundle such that the budget constraint is tangent, no, to the highest possible indifference score. So that is the concept of efficiency. So you want to maximize your outcome given a set of a bundle of X and H, medical care, and H and X and M. So given a combination of X and M, what is the highest possible utility that you can reach? And that is given the constraint of your budget. So given your income, so what is the highest possible indifference score that you can attain? So this will be shown in the next slide. So these are the production possibilities curve. So given a combination of H and X, health and the basket of goods X, this is your indifference curve 1 and this is your indifference curve 2, and these are uh, the curves that shows that for a given set, a combination of H and X, you will have the same utility or happiness, and this is your budget line for optimization. So given your certain level of income, so given a certain level of income, this I, what is the level of medical care and goods, X goods, that will give you the highest possible utility. And this is tangent, to this utility curve. And that is the combination of the highest, the most optimal combination of medical care and X goods that you need to have given your income, given your status. So this is tangent to this utility curve, this indifferent curve. So we say tangent, it meets it at one point, and all other points are equidistant, on both sides of the line. So this tangential to this utility curve. So that is the optimal level of consumption decision given a certain level of income. What is the level of medical care and consumption of goods that gives you a maximum utility? Now, let's take a closer look at the indifference curves for health and other goods when you are sick. So when you are sick, uh, the level of health drops from 8 sub 0, from 8 sub 0 to, let's say, 8 sub 2. So you define the health loss as I. So the curve shifts, so the PP curve shifts inward, and the new optimum is at less consumption of goods and more health as the consumer pays for more medical care. So there's a trade-off between consumption and medical care changes, so that the indifference curve shift with illness. No, with illness you shift towards more health. So more consumption of medical care, less consumption of the other goods, X goods. So the indifference curve will shift inwards to the left. So if the illness, on the other hand, reduces earnings also because of the sickness, the budget constraint may also shift. And this shifting will also uh, be reflected here. So if your income level is also reduced, then the shift will be more also to the left and downward as well. So these are the different levels of impact given sickness condition. So there's a shifting of curve inward, where you have a new optimum with less consumption of goods and more consumption of medical care. However, if the income is affected, you will have lesser consumption of medical goods, of medical care, as well as lesser consumption of goods as well. So let's now go to the effect of income on the consumption of health and other goods. No? So the question is, how does income change medical care consumption? So the graph that you see here on the screen, figure 4.3b, take a look at the effects of income when we hold everything constant and its impact on the consumption of medical care. So this is actually the first step in trying to derive demand curves for medical care, because these are the things that we can actually measure. No? We cannot really uh, measure utility curves, but we can measure and take a look at demand curves. So in any standard economic analysis, we would portray this relationship between income and health consumption as an outward shift, no? Outward shift. As your income increases, there will be a corresponding outward shift in the production possibility. So these are your production possibility, starting with this income level. So you have P, P, and then at this income level, you will have P prime, P prime, and then you have another production possibility here that shift outwards, which reflects the increase in income here on figure 4.3-B, where you have increases in income from this line to this line and up to this line. So these panels will show that there is actually an expansion path. So there is an expansion path or an increase in the consumption of goods, X goods, and H or health, uh, increase in health consumption as measured by your medical care services, holding everything holding everything else constant. So holding everything else constant, we see that the consumption for X and H, or X and M, or medical care, will change with increasing income. In fact, increasing income will have also show increasing consumption for goods like X and medical services. So it is important to remember that in the real world, people with higher income tend to have better health insurance as well than those with lower incomes. And because they have better health insurance, this would lead to more medical care use, as we will see later in our analysis. However, they may also get sick less, more, so hindi sila ganun katalas magkasakit because they have better nutrition, they have better environments, so they will tend to use less medical care. And for some of them, however, when they have higher income levels, like for instance, we see this in our middle class, when there is an increase in income among our middle class, some of them may actually uh, make lifestyle choices that puts them at risk for getting sicker. So in the next slide, I will show to you what we call that reality, which we call life in a fast lane, where increase in income may actually lead to a decrease in terms of health. And we'll take a look at that. But generally, when we look at our income levels, generally you would have correlation with higher income to higher consumption of goods and medical services as well. So the expansion path that we saw earlier can be used to derive what we call Engel curves. Engel curves are your income demand curves, no? So as your income increases, you will see that the demand for health services will also increase, no? There's a demand for health. And what this figure shows to us, what this figure A and figure B shows to us is that at low incomes, when people start at low incomes, we have what we call sanitation effect. And when the people who start off with low income have improvements in terms of income, there's a rapid increase, no? So there's a rapid increase. So this one, this uh, curve line that is dashed, no? This dash line at the lower portion of this curve, lower left, the sanitation effect represents improvements in income that leads to very rapid increase in health outcomes as well. So this is because the initial improvements in income will bring about basic sanitary measures like increase in access to water supply, vaccination, and this radically alters the condition in which people live. So this is important, for example, in poor rural communities in a country like the Philippines, no? Where when you have people with increasing income and better environments, there will be a large effect in terms of health outcomes, and this would be called your sanitation effect because this is the effect of access to water services, access to vaccination, and other services that were not present before. Now, in addition, we also see a situation where which we call uh, when you have people increasing their income levels, there's a corresponding decrease in terms of health. And what is that? Because of lifestyle choices, we call the fast lane effects. The people who have access to higher income will tend to have poor lifestyle choices, like they eat more unhealthy food, junk food, so they can buy an unhealthy food like cheeseburgers or French fries, and they have access to this kind of food that actually have uh, contribution to poor health outcomes. So, so the paradoxically, the increase in income would lead to loss in terms of health stocks. However, if you compare that in terms of medical services, you will see that out the increase in access to medical services for those people who are affected by what we call the fast lane effects, their consumption of medical services, which is reflected in figure B, no, where the pure income effect is supposedly just this score. However, because of the fast lane effects, not the consumption or lifestyle that leads them to unhealthy choices, leads to consumption of medical services above and beyond what is expected based purely on income differences. So that's what you call your fast lane effects. On the other hand, there's the opposite effect as well. When people who have increasing income will have, because they live healthy lifestyle, they produce they access health services less because they're living more healthy, they are making proper choices. That's what you call your health spa effect, where when they increase their income, in fact their medical services access decreases. In fact, their consumption of medical services decreases because they are more healthy as a result of becoming uh, or having access to more income. So their lifestyle choices, in terms of the food that they eat, the environment that they are in, provides them with opportunities to have healthier lifestyle, and therefore their demand for medical services will decrease, which is smaller than what is expected out of the pure income effect as well. So that's the meaning of that figure, your Ingalls score, no? So it could be fast lane effect, the consumption of medical services above what is expected out of pure income effect alone, or what we also have what we call health spa effect, where there is a decrease in medical services utilization, which is less than what is expected out of your income effect only. So then in general, so when we talk about indifference curves, by nature, when you talk about indifference curves and utility curves, they are usually unobservable because we cannot measure utility, like the satisfaction that people have. You cannot measure psychologically how people feel, no, with regards to their consumption patterns. However, what we can actually measure are demand curves, no, which are based on our assumption, based on the utility curves of people. So when we assume that the utility curves determine the demand curves, we are therefore able to conclude that by observing standard demand curves, we will be able to understand how much medical care people would consume given a different set of prices for these medical services. So this is the standard technique that is used in health economics, no? So that for a given level of illness where you have stable indifference curves, uh, when you look at the demand curve as reflections, no, or as proxies for your utility curves or your for indifference curve, no, that the indifference curve being that combination of consumption of of X and health services or health stock, consumption of health services to or medical services. This combination of consumption of X goods and medical services that provides equal, no, or equal satisfaction. You call that your indifference curves. Uh, Now becomes easier to measure because you can just look at the demand curves in terms of how it responds to differences in terms of prices. So when prices of the medical services become, will fluctuate, so become different, then what is its impact in terms of the demand curves when you hold your income level constant, and also when you hold your prices of other goods constant. So this is how you therefore move from looking at indifference curves to looking at demand curves. And looking at demand curve allows us to understand that when you shift, for example, here in figure 4.5a, assuming that medical care is a normal good, it's a good that we consume, an increase in income. So when you have an increase in income, generally there will be an increase in demand as well. So a given increase in income, when you shift your income level, for example, to the right, you have more income, that the demand curve would also increase. So this figure here shows to you the relationship, for example, that happens between consumption of medical services and consumption of X goods when the price for medical services increases. So, for example, here, this is the baseline price of PM sub 1. So this curve is the consumption of X goods and medical services goods at this level, this price level for medical services. What you notice is that when the medical services, when the price for medical services increases, so that shifts, the curve shifts uh, to this point. So you have, this is the consumption of M sub 2 and X sub 2. Your price for medical services will increase. Therefore, the consumption for medical goods will okay. So for 8, so you have a lower price. So if you have a lower price for M, when you have a lower price for medical services, the demand curve will also increase. So when you have decreased price for medical services, the demand curve will increase. But if you have increased price for your medical services, the demand curve will decrease. So in other words, the demand curves will be responding normally to price changes by increasing or decreasing the demand for medical services depending on its price. When the price increases, there will be less demand for medical services. If the price decreases, there will be more demand for medical services. And when you have increased income, you have increased demand for services. If you have decreased income, conversely, you will also have decreased demand for services. So that's how you take a look at your effect of prices on demand for medical services and also the effect of income on the demand for services. Also, when you look at how the demand curve will be affected by the severity of illness, so we would see in this figure that if, for example, this curve here, the relationship between the price of your medical services and the consumption of these medical services, you notice that as the price increases, there will be less consumption of medical services. As the price decreases, there will be more consumption of medical services. So this is for normal health. But when you have an illness, you would see that the curve will shift to the right. So there is a demand increase with the extent of health loss. So when you have illness, there will be more demand for services because it shifts to the right. And given a set of price, no, given a set of price for these medical services. So the more serious the illness is, the greater the shift of the curve in terms of consumption of medical services. So that the more serious the illness you have, the more demand for medical services will be seen, no? Uh, Given a certain price for that medical services. So for serious illness, this will be the willingness of the person to pay for uh, uh, medical services given this set price. And of course, you would see here that this curve is more steeper, no? That the willingness to pay because of the need for more and more services is here because of serious illnesses. Still, you would see that the the higher the price, the lower will be the demand for medical services. However, still the demand is still greater compared to when the person or the individual have normal health for a given set of prices. So at higher income, the demand curve associated with each event would sit somewhere to the right, no, in this figure. So if your income is higher because you have more capacity for paying the price for medical services, it would be on the right side of the figure. However, how much uh, would the shift would be, we cannot tell except if we do empirical studies. So we need actual studies to measure the changes brought about by higher income in terms of its impact on medical services consumption given a certain level of illness. Now, what is useful for us is that we are not interested in looking only at individual patients. We want to look at a group of patients, a group of people in a society, and how we can actually take a look at the different medical services that this group of patients consume. So what we usually do is that combine all of these medical care services. So because health can be affected by more than one type of medical care, and different types of care can actually act as complements, or they are like they support each other, or they can act as substitutes, no, or they can replace each other. So for multiple health inputs, the measure for health in general would be a function where it is measured by combining all of the demand for services, different types of medical services for the several types of illnesses that are available in that particular market. So each type of medical care would have its own demand curve, and you would notice that how do you differentiate medical services or medical goods that are considered as substitutes, or medical goods or services that are considered as complements? So this is an important question because there are different types of medical services, there are different types of goods and commodities, and which of them can be considered as complementary and which of them can be considered as a substitute or competition, no? So complements are actually goods or services that are consumed together. So complements are consumed together because they help each other out in producing health. So an example of this, for example, that would be easy to understand is the use of gasoline and tires. So gasolina and tires as complements in the production of transportation um, vehicles, no? So the use of gasoline and tires, they're different goods, but they have the same use. They allow us to travel to great distances. They complement each other because we need both gasoline and tires. However, substitutes are different. Substitutes uh, are goods that allows us to use less of the others in order to achieve the same result. So when you consume one type of good, then you decrease the consumption of another type of good, then that is called substitute or substitution. So therefore, medical goods are substitutes if the demand for one good rises with the price of another good. So the reason being that if the price of that service increases, then people will consume less of that good, and then they would consume another good which have not increased its price. So when you consume that good, so there's a demand for that good. When the price of this other good increases, then those two goods are actually called substitutes because they fulfill the same function. For example, cars and airplanes, they have the same function. They can transport us from one place to another. So when we ride the bus more often, then there will be a decrease in people riding the plane. But when people ride the plane more often, then there will be a decrease of people riding the bus. So they are substitute in terms of transporting people from one distance to another. So therefore, when we define medical care, we define services as either complementary, or they are complements, or they have substitutes depending on the behavior in response to price changes that we have mentioned earlier. So when their consumption patterns of two types of goods move together as the price of them changes, then they are complementary. If the price changes have the opposite effect in terms of consumption pattern, then they are called substitutes. So these are important policy questions. For instance, questions like hospital care, and ambulatory care. So when inpatient care versus ambulatory care, are they complementary services or are they substitute services? Another question would be preventive and acute medical care. So preventive services, are they complementary or substitute to emergency care or acute care? Uh, these are important questions in terms of health economics because we need to design the best insurance package, for instance, or health finance package, based on the relationship between these different goods. Because if preventive and emergency care or acute care are substitutes, if they are substitute of each other, they could be substituted for each other, then a smart health insurance program might encourage the use of preventive care, because the more preventive care you use, then the less that there would be money or utilization used for acute care or emergency care. So, so it might encourage, if we encourage the use of preventive care, although it might be expensive in the short term, it would save more money in the long term, because there would be less spending on acute medical care. So that's the same question also that we can ask when you talk about inpatient care versus outpatient care. Are they complementary, or are they substitutes? Uh, what do you think? So, for example, when you talk about giving more insurance benefit package for outpatient care versus preventive care, no, or preventive or promotive care, uh, what does it do, no, in terms of access, or in terms of demand of these services? We cannot answer this question based on theory alone, no? That's the problem. We need to have empirical studies to answer these questions, and uh, that's why we need to understand the relationship between these medical goods and services, if we want to understand how we can better manage our healthcare system. Another concept that we want to um, take a look at is the aggregate demand curve for health. So the aggregate demand curve for health actually just adds up the individual demand for that particular good, or for that particular health services at each price. So assuming that three individuals, uh, have this kind of demand curves, no, 1, 2, 3, individual one, individual two, individual three. Then when you combine all of their demand curves, this is what is the total. So we would notice that since individual curves depend on illness, they would shift if individual illness also change. However, when there are changes in the individual curve, you would also have changes in the aggregate demand curve. But usually when we talk about health economics, we're actually looking at aggregate demand curves. And they are based on a theoretical understanding of the individual demand curves as well. So the aggregate demand curves, this one D, the total, adds up at each possible price, level, the total quantity demanded for these medical services. Uh, so that adding all of this will give us a total of the demand in terms of uh, the total services accessed by this group of individuals at a given set of prices. There is a kink in total here. We see in the price 2, at price number 2, where person one's demand begins to add in. Again at P1, where person two's demand begins also to add in. So this is just a reflection of the additional impact of the when you add more and more people to the demand curve. Let's now look at the use of the demand curve to measure value of care. So the willingness to pay interpretation of the demand curve states that the incremental value of consuming more medical care is equivalent to the consumer's willingness to pay for a bit more of that medical service. So this is explained by the fact that the marginal value to consumers or the willingness to pay, no, falls as the amount of consumed rises. So remember, your marginal value is that additional value that is given to us as we consume more and more units of the same service. So there's what we call your inverse demand curves or value curves, because there's a downward sloping of the curves due to diminishing marginal productivity of medical care in producing health and the decreasing marginal utility of each. So we have discussed this in a previous session, where the more you consume medical service, there is decreasing this decreasing returns. No, there's the diminishing rate of returns, so that amount of medical services consumed is no longer as the increase in terms of health is no longer as optimal as you consume more and more of these health services. Therefore, the consumers will increase purchases until the marginal value of M is equal to the marginal cost. So we'll have an example of this in the next slide, where you will see that the total value of a given amount of healthcare is what you call your area under the demand curve, and the consumer surplus is the extra value of the consumers beyond the amount paid for care. So now let's take a look at how we can use the demand curve to measure value of care. So we can extend the same idea one step further by noting that the total value of care to consumers using a certain amount of medical care is the area under the curve. So this is the area under the medical curve. So it might be useful, for example, to think of visit to the dentist as a way to understand this concept. So the demand for having one's teeth cleaned by a dentist and inspected by the dentist is reflected in this figure, where suppose that you visit the dentist uh, each year, no? So the first visit will create a value. Let's say, for instance, that the value of the visit gives you a total of $100 in value. It's because, for instance, you have better looking teeth, you reduce the possibility of having cavities, etc. So you can quantify that value as about $100. Now, if the cost of the visit is $30, the cost of the visit is $30. Therefore, the net value for us, no, the consumer, will be $70, because that's $100 value of care, but we only spent 30, so 100 minus 30, the net value of this visit would give you $30. So for the first visit, a total net value will be $70. Now, assuming that we have another visit, second visit, and assuming that the second visit gives us a value 75, so the value is decreasing. So this is the concept of the marginal utility, or the uh, principle of diminishing returns. So I have decreasing value on subsequent unit consumption of the same service. So in this instance, from $100, it just became 75, but still you paid just $30. So you gain the value on that visit. You gain 75 minus 30, you gain a value of about $45. So that's the value under the curve, the surplus value. So right now, after the second visit, if you add up 70 plus 45, our total net value for the consumer would be $115. Now, assuming that you go for a third visit, so the third visit is valued, the care for that will be valued at $35. Very rapid drop. But then the cost still the same at 30, so therefore 35 minus 5, 35 minus 30, that will give you a net value of 5 for a particular visit. And for the 3 visits that year, adding all of this net value will give you $120. Now, according to economics, we continue to we decide on our behavior of consumption based on the fact that as long as we are the surplus value is greater than the cost, then we'll continue consuming. However, the fourth visit would just give you a value of 20, which is actually less than the total cost during that visit, which is 30. So therefore, the net value of that visit is negative 10, because that's $30, $20 minus 30, that will give you negative 10. So therefore, logically, uh, if you add all of the value that the consumer gets, the value did not increase. Actually, the value decreased. So any logical consumer, therefore, would stop at the third visit, because that is the optimal point in the utilization of your services, that you get the most value out of that demand curve, that for in terms of the consumer surplus for your dental visits. So this is how we explain the value of care in terms of the demand curve and the total net value that we get from consuming a particular health services, like your uh, your dental care visit. And when do we stop utilizing the service? Basically, when the the value of that consumption falls below the cost, the marginal cost of consuming another unit of service. And that will give you the point at which you decide that is the limit where I will consume. No? It's the level of price, the level of consumption that you're willing to do given that particular price relationship. Another concept that I think I will just go very quickly over is the concept of demand elasticity, elasticities of demand curves. So elasticity has something to do with the sensitivity uh, of the particular assessing or consuming a particular health service or medical service given a certain changes in price. So in the figure below, in the left figure, would have changing elasticity as that, because the more the as the price increases, as the price increases, you will have less medical care. So there's an inverse relationship, no? And as the price decreases, you will consume more medical care. So this is an elastic curve. This is a constant elasticity. This is a changing elasticity, I mean. However, this one is the figure in the right has a changing elasticity, so constant elasticity, because uh, regardless of the price, at a certain point, there is very little change in terms of medical care consumption. So that's the difference between the two curves. This one, very sensitive to price changes, in a constant price change will also lead to a constant change in medical consumption. However, the figure on the right have a constant elasticity, because the the consumption of medical goods does not radically change given a particular price, no? Or for example, when it reaches a certain point where there's a rapid increase in consumption, even though there's only a very small increase or decrease in price as well. So this is a more constant elasticity demand curve. And what is also important to note is that when you have a severe illness, the the elasticity the demand shifts, no, to the right. So mild illness, this will be your uh, demand curve. For serious illness, this would be your demand curve. For some more severe illness, the elasticity of demand is smaller in absolute value when the demand is linear. Right. For constant elasticity curves, only the quantity demanded changes, no? Not actually the elasticity. So the elasticity remains the same. So now for our last concept in this session, we now come to one of the key ideas in all of your health economics, and the one which we really need to understand very clearly. When we talk about health economics, we talk about health financing. And when we talk about health financing, we talk about health insurance. So health insurance, the purpose or the reason why health insurance is unique, makes the health market unique because health insurance is usually structured in such a way that it reduces the price consumers will pay at the time they purchase medical care. So uh, the net effect of health insurance is that it lowers the effective prices of medical services. So it lowers the prices of medical services. So therefore, if you use normal laws of economics, if medical care obeys the normal laws of economics, you would see that providing people with health insurance policy should increase their use of medical care. You know, because because it reduces, no, it reduces the prices. So the lower the prices, there will be more consumption of medical services. So that's normal economics. So, however, the major function of insurance in the health market is basically to reduce the financial risk. And the mechanism for us to do that is to lower the price of medical care, which would produce a side effect of increased medical care use, which would in the time would if you, it allows it to do that, that would increase the price of medical care in general. So how is health insurance structured so that it will meet the goal of reducing financial risk for people? So health insurance can be structured in several ways, but there are several features that appear in many health insurance policies, and we need to understand how they work and how they affect demand for medical care so that it will provide us with certain insight into many health policy issues. So the typical features of your health insurance can fall into three particular types or categories. Number one is what you call your co-payments. So health insurance can be structured in such a way that you provide co-payments. The second one is what you call deductibles. It's like you're giving money regularly every year so that you'll be able to use that money when you reach a certain amount of money that you've saved enough money, you can use that to access health services and be given a lower set of price when you have that amount of money. The other one is what you call upper limits on coverage. So we will go over this concept one by one. So co-payment is simply a sharing arrangement between the consumer and the insurance company. So this is specified in the contract so that when the consumer spends money on medical care, the insurance company will pay for some of the expenditures and the consumer will pay for the remainder. So that's called co-payment. And many insurance companies, many insurance are actually structured this way. So co-payments come in several traditional forms. One is a proportional co-insurance rate, uh, where there's like a percentage amount of money that the the patient will pay and the company will pay. The other one is what you call flat indemnity payment by the insurance company. So it's like just a flat payment system that the company or the insurance company will give for that particular condition. And lastly, what we call a fixed consumer copay, where we only pay for a certain amount of money, so the patient or the insured consumer will just pay this certain amount of money for a given service that uh, the access. So all of this, especially the last one, where you have a fixed amount of payment to pay. So when you go to a doctor for, say, an X-ray or for consultation for pregnancy or for an operation like appendectomy, you have a fixed amount of payment to pay that doctor. Uh, and insurance company uh, pays for the rest. So a flat consumer copay per doctor visit, for example, diagnostic exam or ER visit, is the price that the consumer faces. So the flat consumer copay is very common right now in modern private health insurance plans, uh, depending on the nature of the service that is being accessed. So this is easy to analyze, because to find the predicted quantity consumed for this particular service, we just need to see where the copay price intersects the demand curve. So when you have a flat copay insurance plans, these are all popular because these are easier to administer. There's less paperwork to accomplish, less requirements, and doctors and patients really don't know how much they need to pay during its visit. However, the economic consequences is also that when you have this kind of plans where you have a flat payment, there is no incentive to shop for lower price. So you just, because the price is the same regardless. So you don't have incentive to go around and look for lower pricing for the services. However, what modern insurance companies do, they're the ones who do price shopping and then negotiate with doctors in advance with regards to the price, and they're able to control prices this way as well. So your co-insurance, on the other hand, is an arrangement where the consumer pays some fraction of the medical bill, for example, 20% or 25%, or sometimes 50%, especially in dental services, and the insurance company pays the remainder. So if we call the consumer's co-payment share as C, then the insurance company pays a share of 1 minus C. No? So C is the consumer share, therefore the insurance share be 1 minus C. So using the methods of demand theory, we can actually see how co-insurance-based insurance plans alter consumer choice for medical care. So this is reflected in figure 4.9, which shows a consumer demand curve with a particular illness without any insurance. So this one without insurance, and this one with co-insurance with a rate C. So if the consumer's insurance plan that pays 1 minus C% of all medical bills, then the effective price of medical care has fallen to, the price would be CPM sub 1. So this is the effective price, CPM sub 1, when a consumer seeks medical care. So thus, on the insured person's demand curve, we can place point B at the same quantity as point A. So this is point A, point B. So that's the same quantity of medical services that is consumed given a certain level of price, no pricing. The price of PM sub 1. Now, do the same thing at some higher price. For example, PM sub 2. At PM sub 2 produces point C on the original curve, demand curve, and the point D on the demand curve, say point C and point D. So the points B and D begin to trace out the insured demand curve, and when another point which is easy to find is where the original curve shows PM equals 0, no? PM equals, so the price is equals to 0, this curve here. So when PM equals 0, your CP also equals 0. So the quantities consumed are the same at zero market price with or without insurance. Thus, at least as first approximation, we know that a co-insurance type plan must go through the same quantity access intercept as the uninsured demand curve. However, what is not noticeable is that with insurance, each amount of care is less expensive and the demand curve rotates outward. So at a given price, the consumer will purchase more medical care. However, the demand curve is steeper, and the demand curve is less elastic at any given price. So it does not respond as quickly with changes in the price because of the insurance policy that is present. Another form of co-payment is your flat indemnity payment, where which is less common than co-insurance plans. Quite simply, an indemnity plan pays the consumer a flat amount for each medical service consumed with the amount pre-established in insurance contracts. So for example, some hospital insurance policies do this by paying to the insured person some specified amount, such as, for example, for each hospital days of stay in the hospital, they will give you like 5,000 pesos. So the effect on the demand curve is easy to describe using our standard models. And deductibles are also very common feature in many insurance plans. However, indemnity insurance is not as popular as your other types of uh, insurance structures. So deductibles are fixed amount of money that the consumer must pay before insurance payments are made. So the effect of a deductible on the demand curve is quite complicated and depends on the degree of illness and the severity of the illness in relation to the size of the deductible. So figure 4.11 in this screen shows to us the effect of a deductible on the apparent effect price of care. So dropping the price from the original price, let's say P, to about 20% of its normal level after a deductible size of D has been met. So when you have a deductible size of D that is met, which is equal to PM subprime, PM subprime. So this one here, where M prime is the quantity, such that buying just that amount of medical care at the price P leads to an expenditure of amount D. So the 20% figure is arbitrary, but it is a common feature of many major medical insurance policies. So that it's like a co-insurance rate after you have met the deductible amount. Therefore, when you met that deductible amount, you have been able to pay for your deductibles. Therefore, the co-insurance therefore will be zero, no? So you don't need to spend any more money because when you have reached that figure in terms of your deduction, you can have zero price for your consumption of that particular services. So this is quite complicated to understand because there are several points at which the price would be different from point A to point B to point C. And where do the consumer will prefer not to spend money to consume services. So that the answer will depend on the size of triangles A. So this is triangle A, this is triangle B, and the answer on at which point where consumer will demand service will be determined between the relationship between A and B, which is triangle A and triangle B. And the general thing is that if you have greater triangle B than A, you would tend to consume more services at point C. If the triangle is greater at point A, if A is great, if A, the triangle A is greater than triangle B, then there is no reason for the consumer to wait to consume here, but it can actually start consuming at point A because you would have uh, value generated by consuming at point. It's important to note, for example, that for the uh, mild illness or very serious illness, and the result is similar to in insurance. And one of these two, in several places, it is not clear what the consumer choose the option to maximize consumer support. It will choose A if triangle A is bigger than B. Choose triangle B is greater. So because insurance is deductible, reduces the cost of future and usually non-medical treatments. Because it's like depositing money in advance for a disease that you might probably get, but you do not know if you really get it. And only a particular amount of money, uh, the service, which is basically zero, uh, when that particular event happens. So in general, it is similar to an insured demand for illness and to ensure demand for large illness. So this is for what we call catastrophic illnesses. This is like a form of insurance that pays for services when you have like cancer, you have like a vehicular accident, which we do not expect to happen, but when it happens, will give such undue stress, no, to the household in terms of financial requirement. There's also what we call high deductible plans, where you have a typically full coverage for expenses above the deductible, so that this is initially known as your consumer-directed health plans, and this allows people to provide protection against catastrophic risk, while at the same time provides an incentive to reduce unnecessary care as well. Also, we need to remember that in health economics, we need also to take a look at the cost in terms of time and travel costs. So when you have been accessing services, for example, of your outpatient departments, when you go to big hospitals like your PGH or EVMC, you know that one of the costs for patient is that they line up for hours. No, you do not go there and immediately you are attended to. So one of the costs for seeking services is time cost and a travel cost as well. So there is a cost for delay to appointments. So in many situations, it's you are not able to access services immediately, but you have to wait for your appointment. For example, in some countries they have free services, free medical services for the treatment of cancer, but or for transplant of a kidney, but they have to wait, no, like for several years because before they can access that. So that comes into play in terms of, are you willing to pay for that delay? Some citizens, for instance, in countries like this, they would cross to other countries where you can actually just pay for the services. So you can opt for private healthcare rather than waiting for the state subsidized care uh, that don't really have much out-of-pocket expenditure, but there's long waiting time as well. So those are the trade-offs that happens when you have health systems like health insurance situations like this. Also, remember that demand for care is also affected by quality. So the quality of care, when it increases, so the quality of care increases, you will notice that the demand for care will also increase. So that's the reason why more and more private hospitals, if they want to increase the demand for healthcare, they would ensure that their patients are comfortable, so that if you walk in into some of the, for example, I don't know if you have visited the National Kidney Transplant Institute. It's a public hospital, but it has already been modernized, and there is like a private-public partnership, so that when you enter that hospital, you think you're entering a hotel. So it's really comfortable for patients. It's air conditioned. They use modern amenities. So the quality of care increases the demand curves as well. So that there's an incentive for patients to demand more of the services when they notice that the facility or the health services are increased quality. On the converse, if the quality is reduced, if the quality is not uh, high, for example, we have we have many district hospitals and community hospitals that don't actually have patients. They don't line up there. And the reason for that is that the quality of care is not that high. So that it also is also affected by the perceptions of the quality of care, how people look at the kind of services that are being offered. So that these are a complicated issue. Uh, People seeking care in primary care facilities, for example, in the RHU or in the community hospital or in the district hospital, there's the demand for care in this particular health facilities, in this particular hospitals will depend on also the quality of care and availability of care, on all of this linked to the kind of payment system. No, what do we pay? Do we pay for some amount of money? Do we spend out of pocket? And this will all determine the demand for service in those health facilities. And most of all, patients' beliefs and the level of information we have will actually also determine the demand curve for medical services. The consumer's perception of the quality, the productivity, and the desirability of treatment will depend on patient's belief and on the consumer's information. So demand is higher when the patient believes that medical intervention or a specific treatment is more effective or desirable, and demand on the other hand is lower for groups that do not believe in medical interventions or fear unpleasant treatments. And that is why we have problems like this in our vaccination programs, diba? The reason why we have very low uptake in terms of our vaccination programs, because there is this belief that in this conspiracy theory that this kind of services, these medical interventions are not warranted, for instance, COVID-19 vaccination, or that they will lead to more harm than good. So these are issues that we need to consider when we look at the utilization and the demand for health services like vaccination. Lastly, when you look at the price index for healthcare, it's noteworthy that although the prices increases over time, it is also notable that the quality of care has also increased over time. So that's the corresponding relationship. So that if you take a look at this relationship between price and quality, actually in reality, the cost of healthcare is falling over time rather than rising. So the real medical care costs have increased about 70% since the 1990. However, we would still prefer the current healthcare that we have uh, because the higher prices that we pay for healthcare reflects higher consumer surplus. Now we derive more benefit. People are living more. People are surviving more. There is higher quality of services that we receive, and there's increased consumer satisfaction despite rising prices, and all of this will contribute to greater quality of the kind of services that we access in our healthcare system. So I think that's the last slide for this session, and I will end at that slide for now.